Hello, everyone. I'm Andrew Watkins, and I would like to welcome you all to our inaugural podcast episode for the Nebraska ASAP Antimicrobial Stewardship Summit. Due to the COVID-19 pandemic, we're unable to host the 2020 Nebraska Antimicrobial Stewardship Summit in person. So rather than create another Zoom conference or series of live webinars, we chose to pursue a podcast series format. We feel that this will be a better format to plug and play episodes to learn about the content in the midst of busy schedules. We're going to have episodes with experts across the state to discuss antimicrobial stewardship topics relating to both acute and long-term care. CE credit will be available through Creighton University, and more information will be available on the host site regarding claiming credit for that. I will be moderating this episode and would like to welcome today's speaker, Dr. Salman Ashraf. Dr. Ashraf serves as the medical director for Nebraska ICAP, as well as the co-medical director for Nebraska ASAP, which are our state's infection control and antimicrobial stewardship teams. He's also an associate professor in the Division of Infectious Diseases at the University of Nebraska Medical Center and is board certified in internal medicine, geriatric medicine, and infectious diseases. Welcome, Dr. Ashraf, and thank you for joining us today.
Thank you, Andrew. Thank you for this opportunity here.
So today we're going to be discussing UTI guidance for post-acute and long-term care settings that was published by the American Medical Directors Association. And so before we dive into the guidelines themselves, do you want to take a few minutes to tell listeners who may be unfamiliar with AMDA, who they are, what populations they serve and represent, and then what their mission and goals are?
Yeah, AMDA is the Society for Post-Acute and Long-Term Care Medicine, and they represent the nursing home medical directors, physicians, nurse practitioners, physician assistants, and any other practitioners working in these settings. Their mission is to promote and enhance the development of competent, compassionate, and committed medical practitioners and leaders to provide the goal-centered care across all post-acute and long-term care settings. And one of the ways they advance their mission is by publishing evidence-based clinical guidance that the clinician can use to provide, quality care to the patients. So that's how our guidance came.
And so you were actually the primary author on this consensus guidance. How did you and the committee go about formulating these recommendations, and what specific populations do they cover, and did you all have in mind?
Yeah, so Andrew, it is well known that antibiotics are way overused or misused in post-acute and long-term care settings. There are studies have shown that up to 75% of antibiotics prescribed in this setting may be inappropriate. Many of the inappropriate prescribing is related to the UTI diagnosis. AMDA leadership noticed the need of a comprehensive guidance and was requested, and basically I was requested to put together a team that will review the literature, analyze all the current evidence, and then make recommendations related to the diagnosis, treatment, and prevention of UTI. The patient population we focused on is the post-acute and long-term care population, more specifically the residents of skilled nursing facilities and long-term care environments. And as far as how we structured our work group, the first step was to decide on the topics and the questions that need to be addressed in this consensus statement that we were trying to put together. Basically, what we did was we divided the team into 5 subgroups that focused on different areas and look for the literature in those areas. One was to look into the scope of the problem and the background information that we needed. The second group focused on the diagnosis of UTI, the third on the treatment, the fourth on the prevention, and then the fifth group was focused on antibiotic stewardship. Once all of these subgroups did their topic review, summarized the relevant literature, and then submitted the summary to me as the chair of the work group, then we had team meetings where the recommendations were discussed in light of evidence, and further modifications were made based on the discussion until the group reached a consensus on all the recommendations. Then a final draft was developed and reviewed again, and any further changes after that also required a group consensus before it was published. It is important to note that there are several areas where we need further research, and not enough evidence exists to make an evidence-based recommendation. So what we did is we noted on those recommendations which of those recommendations we were making were evidence-based recommendation and which ones were mostly consensus-based recommendations. So if you are going through that publication, you can see those delineations in the summary table, and basically in the summary appendix.
It seems like the committee was put together really well. I know when I went through and was reading through, I was impressed with how well it flowed, how logical it was, and how the recommendations were. And so jumping into those guidelines a little bit, I know there's always a lot of confusion around a true urinary tract infection versus asymptomatic bacteriuria. What are the differences between these two, and how does it affect the way we view this guidance?
Yes, it is very important to differentiate between the asymptomatic bacteriuria and a real UTI. Asymptomatic bacteriuria refers to those situations where someone has a positive urine culture but does not have any signs or symptoms that localizes to the urinary tract. Now, in post-acute and long-term care settings, the prevalence of asymptomatic bacteria is as high as like 50% for female residents and 40% for the male residents. So if we do urine testing on otherwise healthy post-acute long-term care residents without any clinical reason, many of those cultures are going to result positive. However, it does not mean that they have a UTI. It just means that they have asymptomatic bacteriuria, which does not require treatment. Only time we look for asymptomatic bacteriuria and treat in older adult is when they are about to have a urological procedure and expected to have mucosal trauma and bleeding during that procedure. And in that situation, it will be okay to screen for and treat asymptomatic bacteriuria. Otherwise, we shouldn't even be looking for asymptomatic bacteriuria. So I hope that answered the question that, asymptomatic bacteriuria means presence of bacteria in the urine without having any signs and symptoms that are localizing to the urinary tract.
Yeah, I think it answered it perfectly, and you hit on a lot of good points. And like you mentioned, it's still something that we see a lot of in practice, and that through a stewardship role, we're talking to these facilities very frequently about. So really good for people to understand the background of those definitions. Along those lines, I wanted to ask you about diagnosis of UTI. And so what criteria come into play when you're diagnosing potential UTIs, and what approach should clinicians on the front line use?
Yeah, I think before I even dive into that, let's just kind of describe a couple of UTI clinical syndromes here. When we're talking UTI, it's a broad diagnosis or broad terminology we are using. The most commonly encountered syndrome that we see is uncomplicated cystitis. This is basically when the infection is limited to the bladder, and the patient usually have signs and symptoms that are just localized to the bladder, like dysuria, frequency, urgency, hematuria. Those are the type of symptoms that are related or localized to just the bladder. Now, the other syndrome can be pyelonephritis. That is when the infection is now reaching to the kidneys. Anytime the infection is extending beyond the bladder, in this particular document, we classify it as pyelonephritis. So even whether the kidneys are involved or not, if it is extending beyond the bladder, we decided to treat it as an acute pyelonephritis. Some other people, will define that as a complicated UTI, and then the pyelonephritis would actually come under the complicated UTI diagnosis. It just meaning that you have infection limited to bladder versus you have infection when you are you have infection that is extending beyond the bladder. So I think we need to keep that in mind as we go forward. Another UTI syndrome that we can think of can be CAR-T, where the infection is related to the catheter that patient may have. So just keep those broad terminology in mind, and then come back to what you were talking about, is the criteria to diagnose the UTI. It is very hard to diagnose, especially in the residents of post-acute and long-term care setting, very hard to diagnose the UTI. And the reason is that, the diagnosis usually requires a combination of both signs and symptoms that are specific to UTI and then positive urine test results. If we do not have evidence of both, then it is less likely to be a true UTI. However, many of our post-acute and long-term care residents may not be able to describe or mention their symptoms, which makes it even more difficult to diagnose UTI. So over the years, clinical criteria has been proposed to help clinicians working in this setting, who can then use this clinical criteria to diagnose UTI and make treatment decision. And one of them is the Loeb's minimum criteria for initiating antibiotics in nursing home. And this particular criteria describes what minimum clinical signs and symptoms should be present before a clinician considers starting antibiotic for a suspected infection. Now, this criteria was developed about 20 years ago and has been in use by many clinicians over the years. Another criteria that has proven to be very helpful and was published several years ago is basically merged with a communication and decision aid tool in a SBAR format. I'm talking about the AHRQ UTI SBAR tool. That is another criteria that is available, and it is outlined in the guideline that we have published. Nursing staff can use this tool to evaluate the residents for presence of specific sets of signs and symptoms that are included in the tool in a checklist format, and then inform them whether someone is meeting the criteria or not meeting the criteria. And once they know this information, they can pass this information along to the prescribing provider and can request antibiotics if the clinical criteria for UTI is met. If the clinical criteria for UTI is not met, then they can ask for other set of actions that will allow managing patients without needing to initiate antibiotics, which I can explain a little bit more later. There are two additional newly published criteria that clinicians can also use. One of those is improving outcomes of UTI, or IOU consensus guideline, which is specific to diagnose and treat uncomplicated cystitis. And the other one is international guidance or international Delphi consensus decision tool that presents two algorithms for diagnosis and management of UTI in frail older adults. One of those algorithms is for patient with indwelling catheter and another one for someone without catheter. There has not been any head-to-head studies to see which one of these criteria are the best in diagnosing and treating UTI. However, our work group came to the conclusion that post-acute and long-term care setting should adopt at least one standard criteria to guide the diagnosis and decision to initiate antibiotic for residents with a suspected UTI. Any one of these criteria will be better. Following any one of these will be better than not following a criteria at all. And which one to choose may depend on which criteria aligns best with the current practices in order to facilitate the implementation. Another point that I would like to make is that many may be wondering why I'm not mentioning the revised McGear criteria for the diagnosis of UTI. The reason I'm not mentioning that is because the revised McGear criteria was developed for surveillance of infection in the nursing homes. Those criteria are good for monitoring infection rates and comparing the prevalence of infections among facilities. But what they don't what they're not meant to do is not meant to make clinical decisions. So don't use the McGill criteria for treatment decisions, use it for the surveillance.
I'm really glad you mentioned that, because that's actually one of the more common questions we get from long-term care facilities is what's the difference between Loeb's criteria and McGear criteria. So it's really helpful to have that kind of laid out very clearly for the listeners. And so, through all those options you mentioned, when clinical criteria are met. And so, what are those criteria? What types of diagnostic tests would you recommend in the workup of these patients? And, another topic is, what about culturing of the urine? Do you have any best practices for when to collect cultures, how to collect cultures, especially in those patients who have urinary catheters and kind of have their own unique physiology to take into account?
Yeah. So each of these clinical criteria that I described, they either have algorithms, or they have a specific set of signs and symptoms that they want us to follow when we are making the diagnosis. I don't want to go into so much detail on that right now, but those criteria are going to be chalked out when you look in the references that we have on the published guidance. I think I would like to focus here on is what type of diagnostic test we will need in someone meeting the clinical criteria for UTI. So let's say you're following one of the guidance, either it's a low minimum criteria or AHRQ decision aid tool, or the other ones. If you're following one of them, and based on those set of specific signs and symptoms, you have already met the clinical criteria. The resident is already meeting those clinical criteria. Then what are we supposed to do at that point of time? The next step is going to be sending the UA and the urine culture. If the UA does not end up showing pyuria and the nitrite and leukocyte esterase are negative, then it usually rules out a urinary tract infection, regardless of whether the culture shows any growth or not. And then most likely the sign and symptoms, even though it looks like maybe UTI, probably are not UTI. Again, you have to do further evaluation and you have to check with the patient again. But for the most part, if the UA does not show pyuria and your nitrite and leukocyte esterase are negative, then it usually does not, it usually rules out a urinary tract infection. Now, if the UA is suggestive of UTI and a culture comes back positive, then the diagnosis of UTI is likely in someone who is already meeting the clinical criteria. The important thing to remember is that if someone is not meeting the clinical criteria for UTI, then a positive UA or urine culture will not establish a diagnosis of UTI. It may just mean asymptomatic bacteriuria. Now, that is basically the reason we recommend urinalysis and urine cultures should only be conducted for residents who meet clinical criteria for UTI. It is also important that when we have to obtain urine culture, we collect it the right way. In residents without a urinary catheter, a voided midstream or clean catch specimen should be attempted. If post-acute and long-term care residents are unable to provide a clean catch sample, an in and out catheterization then may become necessary. Now, in those residents who have the urinary catheter present for over 2 weeks, the catheter should be replaced prior to collecting a urine specimen. Now, we don't want to obtain urine samples from an existing urine collection bag that is connected to an indwelling catheter. That is not the right way to collect the urine culture. Now, if the urine catheter have been in place for less than 2 weeks, then in our recommendations, the decision to obtain a urine sample from the sampling port of the existing catheter or to remove the catheter before obtaining a urine sample was left for the clinician to decide on case-by-case basis. Either way would be okay. But if it is a patient that you can maybe no longer need a catheter, then it might be better if you just take the catheter out and get a sample after that catheter is taken out. I think that kind of cover what you were looking for in the question, correct?
Yeah, it does, Dr. Ashraf, and I appreciate that. I do have one more question regarding diagnosis, and it's one that we see a lot and we get a lot of questions about from facilities. And where do behavioral changes or altered mental status fit in with UTI diagnosis? I mean, it's something that's seen fairly commonly. So should behavioral changes alone be indicative of a UTI?
In general, we cannot diagnose UTI just because of behavioral change or slight change in mental status. I can understand evaluation for UTI when someone is presenting with a clear-cut delirium and no other obvious reason is there for the delirium, then yes, I can understand that. But other than that, just because of behavioral change, slight change in mental status, it is recommended that we do not pursue the UTI evaluation. When delirium is ruled out and we are dealing with non-specific behavioral change, then we need to look for some other reasons instead of UTI. Did the resident sleep well last night or not? Is the resident in pain? Is the resident dehydrated? Usually when we identify those causes and manage them, the residents will get better. That is where the concept of active monitoring come in play. Many post-acute and long-term care settings will develop an order set for active monitoring. Whenever someone is suspected of UTI, but then do not meet the clinical criteria for UTI, then the facility can initiate active monitoring order set. Now, active monitoring used to be called like watchful waiting. It's not used anymore, the term watchful waiting, because it doesn't describe what we are doing. We're not just waiting, we're actually doing a set of interventions. So what are those set of interventions when we are saying active monitoring order set? It includes maintaining hydration status of the patient, so keeping the patient hydrated, repeated monitoring of vital signs, and performing physical assessments at set predetermined interval, continuing to evaluate for other possible etiologies for symptoms, such as reviewing medication to make sure nothing has recently changed that can contribute to the clinical picture, and also establishing certain parameters on when to contact the physician to provide the updates. So the nurses can be aware of those and can alert the physician if clinical condition is changing or not improving, things like that, while they're continuing to hydrate the patient, and monitoring their vital signs. So most residents will have improvement in those non-specific symptoms during the time that they are being managed on active monitoring. However, if someone is not getting better on active monitoring and no other in the next few days, let's say, and no other reasons for symptoms are identified and UTI is still suspected, then it might be reasonable to proceed with further evaluation and treatment for UTI. Now, I would also like to mention that, another guidance document published by SHARE recently recommends using the confusion assessment method, or CAM, to identify the presence of delirium in a resident of nursing home. According to this method, the delirium is diagnosed when a resident present with acute change in mental status, with fluctuating discourse and inattention, along with either disorganized thinking or altered level of consciousness. So if someone has delirium, then definitely go for the evaluation of UTI. But if you did the assessment and delirium is ruled out, then for this non-specific changes that is not meeting the clinical criteria for UTI, then you have to evaluate for other causes and maybe start active monitoring at that point.
Perfect. Thank you, Dr. Ashraf, and thank you for all those really informative answers about the diagnosis piece. And so we're going to move on to the treatment piece. But for now, that's going to wrap up our discussion of the AMDA UTI guidance diagnosis for post-acute and long-term care settings. Once again, I'd like to thank Dr. Ashraf for taking the time to discuss this topic and to give some valuable perspective on optimal management. I'd also like to thank everyone listening into this podcast, and we hope that it was informative and valuable for all of you that are tuning in. We look forward to discussing more stewardship topics in our future episodes, including the next episode on treatment and antimicrobial stewardship strategies from this AMDA UTI guidance. With that, I will now sign off and wish everyone good health and safety as we continue to navigate the pandemic together.